Hello, everyone. So I'm Ann Goddard from the Population Council. So I will be sort of shepherding us through this breakout room. I'm going to share my screen. We have a case study related to HIV.
Yep, we can see it now.
Great. Okay. Thank you very much. So we have quite a few people in this chat. If you want to, in this room, if you want to introduce yourself in the chat again, that would be great. So we can kind of be aware of who's in here. But actually, let's see. Sorry, I'm just following the directions here. So let me just read through this case study. And then we'll sort of, as Dominic was saying, we'll sort of go through some questions about the case study in terms of the application of the do's and don'ts, which I'm also going to post in the chat so everyone has access to it. It's a link. Oh boy, hold on just a sec, sorry. Okay, I'm now going to post what should be the link. There we go. And you can open this in, it's available in several languages. So you can open it in the language of your choice and reference it as you think about this case study. So I'll go ahead and read the case study. So this is about working with boys and girls to decrease risk of HIV infection. An education project was designed to decrease children's risk of HIV infection. A baseline assessment was conducted to identify teachers and students' knowledge and attitudes regarding gender dynamics, gender-based violence, and HIV/AIDS. An HIV prevention program for students was designed where groups of boys and girls discuss issues related to gender roles, human rights, relationships, reproductive health, and interpersonal communication skills. Through participatory activities, girls and boys explored gender roles, role-played positive behaviors, and learned how to make informed reproductive health decisions that respect their own and others' rights. The post-project survey found that the percentage of students, boys and girls, who thought school was equally important for boys and girls rose from 38 to 60%. Teachers' awareness of the sexual harassment of girls increased from 30 to 80%, and students' belief that they had the right not to be hurt or mistreated increased from 57 to 70%. So I'm going to open the discussion by asking sort of which of the do's and don'ts you see reflected in this program example. And feel free, you don't need to raise your hand or anything, just feel free to speak out.
Well, they started out with an assessment and spoke to both women and men, or girls and boys.
Mm-hmm.
They also started this program early in the life course with children, addressing gender norms.
Great. Anything else?
I think one could say that, you know, they weren't promoting boys' health at the expense of girls.
Great.
Yeah, I think there was the application of gender synchronization in a way that boys and girls were able to have this conversation, so that they took the needs of the girls and the one of boys as well. Thank you.
Thank you. Great. Any other thoughts?
It's not explicit here, but it seems like they engage girls and boys together in the same space.
Mm-hmm. Yeah, I think they did. That's right.
And it seemed to be gender transformative, where they were really trying to move the needle on some gender norms, maybe, you know, harmful gender roles.
Great. Great, thank you. And Are there any other do's and don'ts or any other aspects of the do's and don'ts that you would have sort of recommended they pay attention to based on the description? I know this, not everything is known about this program.
Some of the questions I would ask is what age were these boys, what grade, the boys and girls, what actual combination of education versus skill building was involved, and if any structural issues, for instance, around the functioning of the school and improving that were addressed. Thank you.
Great, thank you.
If I may, I think I would have loved to see a section where some topics were discussed with boys alone and girls alone, just to make it more open and to promote a safe space. Things like reproductive health, just to explore what they feel separately and then bring them back together. That is what is missing in this form.
Great, thank you so much.
And I don't know, perhaps this happened, but I don't know if the parents were brought into this project or were engaged at all with this project, or if the messages only reached the kids, but that would have been a good thing to reinforce those messages with the parents, especially as far as access to education and things, which oftentimes it's not the kids' choice whether they're going to be sent to school or not.
That's right. Great. Okay.
There's also not a lot of information about how they addressed kind of intersectional dynamics.
Mm-hmm. Can you say a little bit more about that?
So it's this goes to the don't overlook the diversity of men and boys. I would say even women and girls in this context. So how did they address kind of different kind of ethnic and racial dynamics as they relate to gender and potential dynamics as they relate to LGBTQIA individuals in schools. All of which is really important, especially when talking with HIV infection.
Yes, great, thank you. Okay, great. I'm going to stop sharing. And feel free to anyone to turn on your video. So thank you very much. I don't have anything else to say. You guys hit all the major points that. So this is actually a USAID developed case study essentially in relation to the do's and don'ts. And so you guys hit all of the major points and even added more. So well done. So I think let's move on to talking about sort of examples from our own work. It could be sort of similar work that you've been involved with. It doesn't have to be with young people necessarily. But sort of some of the do's and don'ts that we were just talking about, or feel free to bring in other do's and don'ts. I guess what's come up for you as you've been hearing the do's and don'ts in terms of what you've seen in your own work. It can be both sort of positive and negative, or positive examples in terms of sort of following the do's and don'ts, and as well as particular sort of perhaps concerns you've had over time in relation to them. I realize there are a lot of do's and don'ts.
Hey, Lisa. I'm okay.
So let me throw one out there. This program, Ronald, do you have your hand up?
Yes, thank you. I want to try to share. Apologies, I'm on transit. My background might be a bit noisy. Yes, I'm Ronald. I work for Care International in Uganda. and I've interacted actually with the presentation today, like about 2 years ago, and it's something that has been really very helpful in our work with men and boys in Uganda. Of course, also our work with men and boys also premised on the 3 approaches, targeting men as clients, working with them as supportive partners, but also as our allies, our champion for change. And of course, this has been, I want to speak partially about working with men as clients. This is an area that is very, very actually of interest, and I like the presentation because a number of times, and especially in our work with the refugees, you find that this is an area which you need to pay much attention to, because in such a kind of a setting also, like they come with their different needs, they come with a lot of their psychological, their distress, and this has a bearing on their behaviors. You find some of the backlash, some of the gender-based violence related things that I imagine is as a result of us not addressing the needs of the men, the stress that they go through. First of all, when you look at the reproductive health point of view, at times women take the stick, receive the blames for not maybe bearing a child, for not conceiving, and yet sometimes men also have their own reproductive health needs where they need to really go and receive some of the support that they talk about, the erectile dysfunctions, the lifestyle, some things around prostate cancer and all this. So in what we've been doing, we're trying to bring men together and make sure that they go and access some of these services. We talk to them about the availability so that it's accessible. But also in what we've done with the Ministry of Health is trying to make the health facility more friendly so that men are able to access services. There's a program when they're looking at prevention of mother-to-child transmission. But again, sometimes the environment around, how is it attractive to men so that when a man is coming together with a wife for antenatal care services, is able to feel that, okay, this is my space. At times, you find a facility has only 2 chairs, one for the midwife, one for the what? For the woman. And there's no chair for the man. And the man say, okay, let me leave you sit there. Let me go and sit under the mango tree. When you're done, I'll put you behind the bicycle and we go back home. So trying to make sure that, first of all, there's even a seat for the man so that he feels like, okay, this is my space. We are I can be part of this and listen to the conversations and also feel attracted to this. So making the environment, the space, and more attractive to men, it was very key for us, and I think something that we look at. But of course, not looking at aspect also the emotional, and of course, because of the way we socialize, sometimes it's difficult for men to open up. So creating that safe space for them to freely talk about their needs, talk about their vulnerabilities has been very key to see that they're able to speak their mind out, they're able to express themselves without being judged, without being stereotyped, that they're not men enough. Yeah, I think for purpose of time, let me stop there. I can talk on and again. Over, I submit.
Thank you, Ronald. Fantastic examples. And one thing I was thinking about as you were speaking was, and that we didn't really point out in the presentation, is part of the model, the men as clients, men as partners, men as agents of change, is that, you know, each of those feeds off each other, and you can create sort of a virtuous cycle, if you will, if the more you can address all of those, or at least 2 of those sort of within a given project, the better. And so you get some of that movement forward. Any other thoughts either in relation to what Ronald's just shared or your other experience, Charles?
Thank you. My name is Charles, and I work with Mothers to Mothers based in Nairobi, Kenya, where we implement a maternal and child health program with elements of RMNCH, PMTCT, and others. And some of the activities that we engage in: first, we promote HIV testing for all pregnant women. Unfortunately, some do test positive at the first clinic visit, and they are then encouraged to relay that kind of information to their sexual partners back at home and encourage them to come to the clinic next time for male partner HIV testing. But over time, what we learned was that because of the endemic culture of gender-based violence in Nairobi, men do not receive such kind of news positively. So sometimes it can result into violence. Other times it results into family breakup and expulsion of the woman from her home. So how do we address that? And of course, this speaks to the don't engage men at the expense of women. So how we cross that bridge is that we advise these women who have tested positive for the first time. We tell them that, would you please go home? If you feel safe to disclose your status to your husband, that's fine on your own assessment. But if you don't feel safe, then just encourage them to come with you to the clinic next time. And when they come, the couples are tested afresh as if the woman had not received a prior HIV test. And that's when now the man is able to view the results by himself. And then of course that time they have undergone pre-test counseling followed now by post-test counseling. Yeah.
Thank you, Charles.
Thank you.
That's very helpful. Thank you. It'd be nice you've given a thumbs up. So thank you. Let us know if you have specific thoughts. Does anyone else have thoughts about how the program Charles is describing, what other approaches could be tried, etc.? These are not easy things to figure out in programs. So I actually happened to be just the other day reviewing a systematic review of interventions to improve male partner involvement in PMTCT in sub-Saharan Africa. And I'm seeing that enhanced psychosocial interventions and complex community interventions were found to be most effective versus sort of invitations on the part of women. I certainly would also underline the, potential risk to women, especially in contexts with high rates of GBV. But all of that also depends, I think, on what the funding is and what the donor wants. So that's always an important part of the mix. So let me invite anyone else to bring in examples from their own work. I'm happy to put a few out there. To be honest, we developed these do's and don'ts in the first place mainly because of the don'ts. We did see a lot of examples of programs in the field carrying out some of the don'ts, I'd say, and that those are becoming actually more common as sort of donors were saying, hey, you have to reach men. And so programs and NGOs were scrambling to do so in ways that weren't always optimal or most effective. I'm happy to throw some of those out, but I'd also invite anyone else to contribute.
If I could just ask whether there is any thinking and programs around how to incorporate men-on-men violence, because I think as we're entering the space, the focus is on gender-based. Mm-hmm. But I think those two are not, perhaps we should be thinking of it together.
Absolutely, yeah. It's interesting because this, the METF technically has these specific health areas we focus on, but absolutely. I think that is to some extent incorporated into sort of what we consider sort of harmful masculinities, I'd say, that are damaging not only to everyone, it's damaging to everyone, including men themselves. But I think that's an example, kind of like Ronald was talking about, of, that it may very well be that violence between men is first and foremost the issue in men's lives. So discounting that for the purposes of a particular program focused on gender-based violence or sexual reproductive health is not helpful. So I totally agree. And I think we need to actually pay more attention to that, particularly in high violence context, high community violence context. Thank you.
I can just add, it's less my personal work, but you know, just an anecdote
Sure.
I saw yesterday that kind of encapsulates a lot of what we're talking about. I was in Mary Center, which is a community health clinic in Washington D.C. that primarily caters to low income communities, and particularly the Latinx population in Washington. And I was there midday, and I think I was one of only maybe 2 or 3 men, and almost every child that was there was with their mother, right? And it's middle of the day, so this is a work day, and there's not a lot of women in Washington that aren't working, so really, I don't think I think you see, the fact that, gender norms like, the unpaid care burden that's placed on women, can also have this kind of transitory effect where, men themselves, individuals, also aren't seeking healthcare and things like that, because there was, individual women there as well, but really only, just a handful of them out of maybe 20 or 25 folks. So kind of the interplay around those gender norms, and equitable gender norms, and how they might actually have, negative health consequences for men themselves. Somebody even mentioned male to male violence, right? Which is also ensconced in a lot of harmful gender norms. I think kind of those interplays, I think, are always important.
Great, thank you very much. Any thoughts about that, folks? So this is
sounds like, I'm so sorry. It sounds like the structural barriers that last don't seems to come up quite often. I think it was Ronald that mentioned just literally not having a chair for the man in that space. The environment that is created has to really be conducive to inclusion. And so my practicum is now with the HIV Health and Human Service Planning Council in New York City, and trying to engage younger men in particular, because the council is aging as folks, at least in the United States, with HIV are aging. And what they found was that literally not accounting for these younger folks to be able to get to the council meetings from school, not having them at a time that school isn't, in session. Those were just very basic things that were kind of perpetuating the structural barrier of keeping these younger men from being part of the planning process. So I don't have too much to add because I'm just starting, but it does sound like, at least from listening to all of the comments, that those are things that often come up and need to be considered in the don't.
fantastic, thank you. Yeah. Any other examples? Ronald.
Yeah, I think just from the previous speaker, something that also maybe comes a lot is us who are providing these services. We need also to question ourselves, our notions around some of these gender norms. Sometimes we come with our biases that also prevents also like a kind of a barrier to men from accessing these services. Painfully, one of the clients that I worked with who had gone through sexual violence was raped during the process. Unfortunately, went for service, and the service provider was asking, is it even possible, kind of like making it even hard for this man to access services. So it's very critical for us also to question ourselves, also look at some of these norms, and also try to see how we transform ourselves so that when we are interacting and receiving people for different services, we are able to be mindful about our own biases so that we don't do more harm in the process. Thank you.
Thank you, Ronald. Gabriella?
Hi, yes, good evening. I think, yeah, I'd like to share experience. I think this maybe falls under more the don't. In my previous job, I manage a program that aim at increasing men's engagement in responsibility in caregiving, but through as a digital. So this was a digital health program through SMS, and the I think, looking back, the one of the weaknesses was that this intervention was that we simply focused on the messages, but we did not look at it as a holistic, trying to address the root of the inequality, the problem in the society. So it was simply to get men to a health facility for ANC and to support their partners during delivery. So only, I think, 1.5 years into the program that we realized, hey, look, we have been working together with health professionals. This is a good entry point to discuss about this how pervasive GBV is in our society, and they could be an agent of change to support these couples. So we started working with organizations that work on preventions of gender-based violence and protection program to provide training to health professionals. So they provide a survivor-centered approach, patients, more empathetic, respectful support to the patients, particularly women who come for treatment. So this is something that I learned, but I wish we had learned about it sooner. And given the project, the funding was very small. There was very little that we could do, though there were a lot more that we could have done to really have more transformative changes. Thank you.
Thank you so much. Fantastic example. Anyone else have reflections on what Gabriella or Ronald were just saying, or their own examples? I think one thing I'm hearing come out is the importance of sort of multi-level intervention. So not only, I think what we frame it as men, reaching men as client, engaging men as clients, engaging men as partners, engaging men as agents of change. But we need to recognize that men are only the individual, individual men or partners even, or the individual man as an agent of change is kind of, at that center of, what we can think of as this socio-ecological framework. And it's critical to have as much as possible, as much as funding allows, et cetera, as much as funders want, the sort of outer ring surrounding that individual man, surrounding that partner, the structural environment, the healthcare environment, the community normative environment, the policy environment, et cetera. And sometimes that those are, in fact, the most critical pieces. So I'll bring in one final don't, which I think led me to sort of conceptualize the do's and don'ts in the very first place, which was don't start with the assumption that men are bad actors. That's something I'm thinking a number of you often see in the field, that there's an assumption by policymakers, there's an assumption by healthcare providers, et cetera, that men have negative intentions or just don't want to engage. And that, as several of the previous speakers brought up, can sort of have a blanket effect on the approach that's taken in terms of often actually focusing primarily on the individual man, and not only focusing on the programming on him, but focusing on what he's doing wrong or framing it in a negative light. So I think we've moved well away from that as a field, but that still does show up. It's remarkably prevalent. I think you know, we've talked in our METF group about how we're very much a bubble, and even our larger listserv group, you know, we're a bubble who considers the importance of positive sort of male engagement for gender, to promote gender equity. But a lot of these do's and don'ts, I think we need to be very cognizant of when we're outside of our bubble as well. Does anyone have any final thoughts? I think we're about to close out the session, this working session. You'll move on to another facilitator. You'll stay in the same group. But any final closing thoughts? Gabriella?
Hi, sorry, this is more a question. Sorry, I'd like to ask how can program engage or involve faith leaders who are often, you know, especially in quite conservative countries, who have very key positions in changing, helping with behavior change or getting people to do things. Thank you.
Thank you very much for that question. Does anyone want to offer a response? That angle is not explicitly incorporated into the do's and don'ts document, but is obviously very critical. Does anyone have experience doing that? I do feel like it's a neglected area I mean, I'm in research. Ronald, I see you have your hand up. I'm in research, and I think it's certainly a neglected area of research. I've seen a little bit more in terms of curricula and programming. I haven't been directly involved in that. Ronald.
Yeah, I think for me, we've worked with different faith-based institutions, and also with religious leaders who both from the Muslim and also the Christian point of view. And for me, from experience, has been a success. The point is, first of all, having that opportunity, creating that space for them to reflect and look at, first of all, looking at the positive, looking at the future, what comes out of this kind of engagement. And we've had, even among our role models, some of the religious leaders who have been able to use some of the positive verses from the Quran, some of the positive bits of the Bible to really reach out to the men. Because, you know, sometimes the interpretation of some of these holy books, it's a challenge to many people. People sometimes...
Further. Anne, did you want to say something? I see you.
Hi.
Unmuted.
Thank you. So we're actually in the process of switching. So hello, everyone. Unfortunately, Peter was just kicked out into another group. So my name is Ann Goddard, and I am going to launch us into another case study. And I encourage you all to turn on your videos. I'm sure you've already maybe shared in the chat. Oh, no, our chat probably restarted. And I'm going to start a recording. I can. Oh, I think it's still recording. Okay. So hello again. So again, I'm Ann Goddard. I'm with the Population Council in Washington, D.C. I'm a researcher working longstanding work around male engagement and across the various topical areas covered by the METF, so sexual and reproductive health, gender-based violence, etc. So I think we have too many people on here to introduce ourselves. So let me share my screen with the new case study. Let's see. Okay. All right. Okay. So let me just read through this case study. So this is about working with boys and girls to decrease risk of HIV infection. An education project was designed to decrease children's risk of HIV infection. A baseline assessment was conducted to identify teachers' and students' knowledge and attitudes regarding gender dynamics, gender-based violence, and HIV/AIDS. An HIV prevention program for students was designed where groups of boys and girls discussed issues related to gender roles, human rights, relationships, reproductive health, and interpersonal communication skills. Through participatory activities, girls and boys explored gender roles, role-played positive behaviors, and learned how to make informed reproductive health decisions that respect their own and others' rights. The post-project survey found that the percentage of students, boys and girls, who thought school was equally important for girls and boys rose from 38 to 60%. Teachers' awareness of the sexual harassment of girls increased from 30 to 80%, and students' belief that they had the right not to be hurt or mistreated increased from 57 to 70%. So this is our case study. So I'll just start off by asking sort of which of the do's and don'ts you see reflected in this program example. And I'm not sure if Peter shared the link. Let me put this in I'm putting in the chat the link just in case you need it again to the do's and don'ts document. Again, it's available in several languages, so feel free to select the language that works best for you. So, any thoughts?
Hi, I can start. Yeah, so one of the do's that was followed is gathering evidence with boys, given that the students were, I guess there was a baseline assessment that gathered information about their existing perspectives and attitudes, which I'm presuming included both boys and girls.
Right, I think it did, yeah. Great, thank you. Anyone else?
Another one is starting early in the life course as well.
Great, thank you. What about the attempting to sort of transform harmful gender norms? It could be another one, perhaps. What about how well the program, I know there's not a lot of information here, obviously, but how well the program sounds like it addressed each of these, and whether there are other aspects of, particular do's and don'ts that it could have addressed better. So what about the aspect of engaging sort of boys and girls, both boys and girls within participatory activities? I'm wondering if anyone's come across in their own work, I know I have, questions about whether to include boys and girls, men and women in the same within activities together versus separately, and what the pros and cons are. I can't, I just in case anyone has their hands up, I can't see that right now since I'm sharing my screen, so feel free to speak if you do have your hands up.
And I don't have an answer to your question, but I was thinking of another do and don't, which is actually listed as a don't, but it's a do in this case. that we don't want to overlook scale and sustainability for achieving impact. And I was just thinking the way that this project is working through schools offers a really terrific opportunity for scale and sustainability.
Great point. Thank you very much. Yeah, so there's a potential to sort of institutionalize this type of program for scale. If you're, we don't know the context necessarily, but we do know, a lot of these types of initiatives can tend to be sort of more pilot programs or sort of geographically limited for study purposes or for a particular funding purpose in a particular state of the US or a particular county of a country. But the fact, I totally agree. That's very true that because it's within and implemented within an institution with the schools, that it could, if it hypothetically was integrated into a curriculum, that could become very cost effective, or just if it just becomes part of the curriculum rather than something that a funder or the government has to additionally fund on top of the regular curriculum. Great.
I hope this isn't off topic, but one thing that I like about this example a lot is that it works across multiple health areas. So it focuses not only on prevention of HIV/AIDS, but also on prevention of gender-based violence. And I'm kind of wondering, and maybe others on the call have opinions about this, but I wonder if it should be added as a due to the guidance that to work across health areas, because I just know like there's so much advocacy these days in terms of health system strengthening and breaking silos between health areas, and that's a priority for a lot of ministries of health. But yet something that personally I've struggled with oftentimes in brainstorming and collaboration with some colleagues is that when working with health experts, oftentimes they're specialized in a specific health area, and it's hard for them to engage when you're talking about health areas they're less familiar with.
Fantastic. Absolutely agree. Yep. And you're right. It should be. That was occurring to me before you said that.
Right. Because I think the benefit of it is like if you're already going out of your way to and investing resources in engaging with boys and men, for example, on one topic, and you're doing it in a way that's kind of more general in nature, not getting like too in the weeds necessarily in terms of the technical stuff, it should be pretty feasible and cost effective to also include information about other health areas.
Exactly.
But I know there's pros and cons of that. I've heard from some people that in certain cases that has not worked that well, where men see, or it can sometimes see that additional information is not necessarily being as relevant for them, especially when talking about things like maternal health in the context of like contraception and family planning. And there can be too much information, but I'm guessing there's best practices on how to do it more effectively.
Likely, yes. I would say one of the dues, I believe, is related to the gender transformative angle. So I think, the theory is that harmful gender norms, or how equitable or inequitable gender norms are in a context, as well as sort of relations and dynamics within at every level of the socio-ecological framework. So, but certainly within couples, for example, has a fundamental effect and fundamentally shapes lots of different health outcomes that we care about. But I agree still, even when you do that and you prepare a program, for example, you can have the funder, I've had that happen, come back and say, well, this is outside of our purview. It's fine to go a little bit broader, but let's not go too broad. Whereas in reality, that it also best meets sort of the life context of most people, right? Because we're not issue siloed in our own lives. I'll just give a really quick example from a big randomized controlled trial, cluster randomized controlled trial I worked on in South Africa, funded by NIH, which, believe it or not, had as the main trial outcome gender norms. So the GEM scale that's developed by my colleague Julie Polowitz, that was the main trial outcome for an NIH trial, and I really appreciated it. I could not believe that NIH was willing to fund that. It was in the context of HIV prevention and gender-based violence prevention, but that was amazing. And so I think that speaks to, you know, funders included and governments recognizing gender norms as sort of this one of these major drivers across multiple health areas. And it's important to address that. I will say at the same time, it was difficult working on the curriculum of that program. You know, you start to pile on lots of different health areas, lots of different issues in people's lives. And so it can become quite a complex intervention, including for the facilitators to implement. It's a lot of different content that they have to get their head around and internalize, and you know, in order to communicate effectively. And it's a lot to ask participants. This is a workshop-based community mobilization, but workshop-based, and so we have tons of different activities and workshop topics, and so it needs to be a balance essentially. Okay. So we've started a little bit to talk about the application in our own work, but I'm just wondering what's been coming up for you guys in terms of your own work as you heard about the do's, you know, Julie go through the do's and don'ts in her presentation, and then Myra talk about the application in the Champion Project. And then with the different case studies you've heard about, what's sort of coming up for you as front of mind in terms of maybe your own current work or past work, either positive examples or negative examples that stand out? I know it's a very broad question.
Yeah, I think one of them, and I think there have been some pretty positive examples shared of this, I think is the importance of like baseline assessments combined with a very thoughtful recruitment approach, because I've encountered a couple of examples of programs where I think there was initially a struggle to recruit a critical mass of men and boys for a reproductive health focused program, and then they sort of like broadened and changed the parameters to make it easier for them to participate, which was good, but it also was unclear whether the participants were already feminists and were already the most inclined to have strong beliefs in favor of women's reproductive autonomy. And so I think there is a risk sometimes that if you're like, unless you're kind of going out of your way to find the populations and communities that do have the greatest need for gender transformative interventions, that you're not necessarily having the greatest impact if you're kind of like preaching to the choir, so to speak.
The low-hanging fruit.
Right.
Yeah. Great point. Anyone else have thoughts about that? It's not an easy thing to address. There's certainly a lot of focus on sort of reaching the hardest to reach, perhaps in particular. I work mostly in HIV, but everything's cross-cutting. I think there can be a danger to that, I will say, in getting stymied because you feel like it's impossible to reach the hardest to reach, you know, and maybe going overboard with research in some ways to find exactly who it is you're supposed to reach. I do think there can be a benefit, a sort of secondhand benefit to shifting the normative environment. For example, you're getting, you know, a majority in, your late adopters, you know, in the sort of diffusion frameworks, the late adopters are going to be out there, but you're moving forward, you're shifting norms for the people you can reach. You do your best to get a range, and then, you know, you're sort of changing the context, and those late adopters may come along. It's not ideal, and obviously you do want to reach them as much as possible. I guess it's like all things, a balance.
if I can give an example of our experience in Ethiopia, we have health extension workers that are primarily women, and usually they go house to house during working hours to discuss with women about health issues. So in our project that we're implementing, we found out that men were not getting the necessary information, though sometimes they are the ones who have the economic power to make those decisions. So we tried to introduce a system whereby health extension workers would have a talk with agricultural extension workers, who are mainly men, to address some of these health issues in order to bring the men into, familiarize them with the necessary information as well as other things. One other point I also wanted to mention is engaging men in their own group. We also found it to be important, because when we put them together, again, coming from a very patriarchal society, the women usually shy away from giving their comments and would just agree to what the men are saying. But when we have them in their own group, in a session that is facilitated by a woman facilitator, that they would really express their true feelings and true experiences. So I wanted to just give an example of those two, like one don't and one do, that we incorporated in our previous project. Thank you.
Thank you. That's great. Yeah, I think that the do or don't, I can't remember, about engaging men in groups with other men versus women, and we should include other gender identities as well. I think what we landed on was essentially the more you can engage men and women and other gender identities as in together as well as in separate groups, depending on the topical area or what your program is dealing with, the better. And that you should avoid doing. I'd say there is a danger, in my experience, of there can be a strong tendency to want to engage men in just men's only groups, and oftentimes, as it sounds like happened in your program, that this need comes up during the course of a program. It's not something that's sort of foreseen at the outset, and perhaps you're just not getting the participation of men that you wanted in your program. And so you start inviting them to their own meeting. You get, send invitation letters specifically to them. You have their own, meeting space where you're talking about issues that are particularly relevant to them. That's important and good. But then a lot of times those same men are not then also participating alongside women. So I think a lot of the programmers and researchers have landed on that as quite problematic. And so I think that in the end, the recommendation is to do both as much as you can. And I know, for example, Rachel Jukes and the Stepping Stones curriculum, the gender transformative sort of community mobilization community workshops, they've also landed on that over time, that's a very important approach. So just be aware of that history. Okay, any other thoughts? I'm not sure how much more time we have, but we'll just keep going until we get kicked out. Any other do's and don'ts you want to talk about? For example, assuming that all men are bad actors, which I'd say was the main impetus for us developing the do's and don'ts in the first place, because outside of our bubble of male, being pro male engagement, and we're seeing a lot of that among even funders, but also governments, policymakers, etc.
I just have a question for the group. This is Mary Beth Hastings. I'm with FP 2030. In terms of male engagement in antenatal care, And just wondering if people have heard of, you know, along these lines of men are not all bad actors, you know, the kind of positive engagement of men in antenatal care, and has that ever that you all know of led to a postpartum family planning program involving vasectomy, or anything along those lines of, you know, engaging men in family planning through maternal health programs?
I would think it has. Maybe not vasectomy specifically. Anyone? I think just one thought is engaging men across, essentially, as we were saying, was it this group or another group? He might have dropped off. Engaging men across health areas is really important. Actually, Julie Polowitz and I are currently working on a systematic review of male engagement efforts across health, across sexual and reproductive health as defined by WHO, so including gender-based violence, maternal and child health, HIV, etc. And one thing that's becoming clear is that these health areas are quite siloed in terms of lessons learned and in terms of approaches being used. And we know obviously funding is quite siloed, but the reality is, you know, issues are not siloed within people's lives. And so, you know, the more you can engage men in one area, that very well may have an effect on other areas of their life. And so, and later on in their life course, and including in the, you know, with postpartum, for example, as you were saying, Mary Beth. Okay, Katanta.
Yes, Anne. So as part of Champion project implementation, we are doing one of the activity called Gender Fishbowl. And during Gender Fishbowl, many times you'll find at the end of the day, the issue of infidelity, the issue of male and female to have space for discussion. So as part of Champion project, one of the deliverables, we developed a curriculum for couple connecting, where we used it for prevention of HIV. So currently, I'm working with Gender Health. We are implementing family planning project. We are also addressing the issue of maternal health. So we have used the connected curriculum to conduct intergenerational dialogue, workshop in the community, couples, especially young couples, to come into these workshops. And then through these workshops, we do invite, or we approximate the availability of services, information, and even, and they opt different kinds of services. But also, we do identify some of the community members as the champions, who we do invite them to go and work with us in the community, but at the same time, they go and speak during the antenatal visit with women. They talk about family planning, they talk about PPFP, they talk about HIV, they talk about the importance of gender equality and things like that. So I believe, and we are starting seeing the spark of uptake, for example, of immunization vaccinations, by starting involving men from the beginning, and especially men who are married. Once they appreciate, they go and speak to other men. So things have been changing. So I think that's my contributions. I would like to add on it. For example, currently I'm running a platform called Tanzania Boys and Men Ambassadors, whereby this platform is providing a safe space for men. They do come, they ask different questions from social aspect to health aspect, and we link them to different healthcare providers. If they need legal services, we link them with a legal service. If they need health services, we link them. And we are telling them the service is not necessarily the treatment, the informations, the consultations which they're getting there, at the end of the day, you'll find some of them, they're even now coming as their couples. So that's my contribution from the previous question you asked. Thank you.
Thank you so much. Amazing. We're going to have to invite you back to present about your programming to the
Oh, yeah.
So I'm going to write that. Yeah, that's fantastic. Thank you. And I especially love the point about engaging men and young men as champions to promote and continue the work in terms of increasing scale and sustainability. Fantastic. Anyone else have thoughts? I see that Claudia asked, I would love to hear experiences implementing male-only groups and avoiding reinforcing harmful gender norms. Very difficult question. I can offer a little bit of advice, and I think to pay attention to the sort of the gender continuum in terms of, for example, if it's a group, a facilitated group, you want to pay attention and make sure your approach is gender transformative and not gender sort of accommodating, and that facilitators are very well trained and retrained, and you do mock sessions, you know, when participants may bring up ideas that are harmful or not necessarily even harmful, but not even gender sort of sensitive. So I would direct you to that gender continuum to think through that. I definitely think there's a risk of when facilitators get in groups, and if the main goal of the program is, for example, to get men into HIV services, for example, that's your end goal, and you want, to some extent, I can understand that there's a desire to sort of pander to men and in order to sort of get them into those HIV services, for example, or whatever that outcome is. So that's, I think, where it can get difficult. So I think, again, training, retraining, et cetera, and really foundationally basing it around the gender transformation.
Thanks.
Not easy though. I will say though, also in our work, we found it can be very important for men to be able to express and to introduce in the curriculum, what stressors they're experiencing, and, just things they want to talk through in their own life beyond the particular topical area of whatever it is. That can also be quite transformative for them in a lot of ways. But again, it's still important to get them engaged in other activities, including especially activities that are alongside women and other gender identities. Any final thoughts? I'm assuming we're going to get kicked out of the room in just a minute. Has anyone seen a 5-minute warning? I haven't seen that yet. I'm not sure if that was put up or not. Let's see. Any other do and don't? Does anyone have any questions about the do's and don'ts? How to apply them, or why certain things were included? What about not overlooking the diversity of men and boys in the population? To me, there's a lot of different, any population you're working with is going to be very diverse on lots of dimensions, and even in terms of sort of gender attitudes, for example, or something like that. That there's a lot of complexity there. So how, as like a program implementer or even a researcher, how do you begin to unpack that? How do you build that into your program without going crazy? I do see under that don't, there's sort of it says don't overlook the diversity of men and boys. I think we're gonna leave the breakout room. But it talks about focusing on the most critical dimensions. So that's maybe through early research without going overboard, hopefully, that you're identifying what are the critical dimensions, what are the critical aspects of diversity that you would need to address in your program. All right, so I think we're gonna leave in about 35 seconds. It's been great to interact with all of you, and I hope this has been helpful to you, and take care.
And then we can close out our webinar today. Before Peter jumps in, I really appreciate everybody's time and you know, just tuning into this event. We had a great turnout today.